This was a figure kind of really put together, suggesting that, the cancer survivor themselves, there's a lot of things that impact them. There's on the outside bar are those physical things that can be both acute, but also can be long-term and late effects of treatment. And then there's really sort of effects directly on the cancer survivor, like social isolation, struggling, why did this happen to them, loss or changes in employment or relationships, as well as the psychosocial impacts. If you look at different studies, as we've made advances in having a larger number of cancer survivors, many actually have a larger number of chronic health conditions. So this was a publication. There's actually been several publications, but I chose to highlight this by my colleague, Dr. Arjun Gupta, that looked actually at the adjusted prevalence of functional limitations in cancer survivors. In this large cohort, when you look over the last couple of decades, there's a growth actually in the number of individuals with functional limitations from 57% in 1999 to about 70% in 2018. There were certain populations that were much more affected by this, for example, the Hispanic and Black survivors, as well as those affected in middle age. If we think about our youngest patient population, like our childhood cancer survivors and our young adults, there's about a 40-year cumulative all-cause mortality, about at 23%. And part of this is from cancer, but part of this is from other comorbidities like heart disease. The encouraging thing about this is that if we control lifestyle factors, like hypertension, diabetes, as well as tobacco use, physical activity, there's about a third less health-related mortality. So anyone who's been in clinic with me will hear me say, keep moving. And we all have to figure out what that means as we get older, but I would say it's a common thing that you'll hear. So part of that with Liz and Kaya, who've been on the calls here, is really to think about how do we develop survivorship care for all of our patients. And this can be an understanding of the treatment people have had. It's understanding the psychosocial impact for patients, as well as how do we actually develop profiles to make sure patients know how to screen for recurrence as well as for new cancers. Also thinking about education about how to stay well and what are some of the late effects from their treatment, but also giving them opportunity to understand where there are resources for nutrition services, physical activity, weight management, psychosocial, as well as addressing some of the impacts on family and caregiver. And I'm thrilled to see all of you here today. So I mentioned to you that we've had a lot of advances in the technology and our understanding, but it also raises the question, is cancer becoming a chronic disease? So our goal still remains to try to cure patients and that cancer is gone. But I would also argue that in many cases, for patients where their cancer is spread to other areas of the body, they actually live with their cancer for many years. And technically, we think about a chronic disease as something that lasts over a year. It requires ongoing medical attention, and in some situations, it can limit daily living activities. Many cancers, particularly advanced or metastatic cases, really fit this description. And in some situations, the goal of treatment is not always a cure or completely eradicating the cancer, but is oftentimes disease control. And that may mean keeping the cancer stable, minimizing symptoms, and really extending survival and quality of life for many years. I mentioned a few of these forces with the advances in technology, but this is also seen in some other diseases, for example, with targeted therapy. So chronic myeloid leukemia, for example, is a type of blood disorder where we really understand the genetics in the cancer. It's a specific mutation. And there are certain drugs or tyrosine kinase inhibitors that block that mutation. And it allows for a long-term suppression of the cancer. And many people would describe this as it's akin to taking insulin for diabetes. If you stop the treatment, those cells will rapidly grow in an abnormal way. But with taking the medication, kind of like insulin, people can live a very long and healthy life. I mentioned to you a little bit more about some of the advances in melanoma and lung cancer as well as in breast cancer. So if you're living with cancer, how do we actually balance the therapies as well as the toxicity of the drugs? And think about this broadly as the 5 years, survival rate for cancers combined is now close to 70%, which really means that for 2 out of 3 people diagnosed with cancer, they'll be living for at least 5 years, and many will live for much longer, as I showed you in that graph. Some of this has been a shift from acute to chronic when we think about treatment focus, where we want to think about cure, but sometimes with long-term control, you also really need to balance quality of life. There's a need for standardized survivorship care. I don't think it's necessarily a care plan, but an integrating kind of with primary care. And it's really common with cancer when you're first diagnosed to lose track of your primary care provider. Some people never had a primary care provider, but I would say as individuals live longer with cancer and they get older, it's really important to have a primary care provider to help manage a lot of these other preventative diseases like hyperglycemia and high blood pressure. That's really their wheelhouse. And many oncologists can manage those, but I would say you really want your primary care physician involved. And then if you're living with cancer, there's also really the importance of understanding the impact of this on the patient, yourselves, but also on caregivers. And it can be very challenging to live with uncertainty of, is my cancer going to spread? Is it going to change? Do I need a new treatment? How is that treatment actually going to impact me, as well as managing side effects? And there's a lot of things that can go into thinking about cancer as a chronic disease. This was a recent publication I worked on with several colleagues, actually looking not only at the impacts of cancer therapies and the underlying biologic mechanisms, but the fact that comorbidities, there's environmental factors as well as lifestyle factors that can really impact actually the risk for chronic health conditions. So how do you keep living well beyond cancer? This is something as a cancer community, I would say, as we design new therapies, we oftentimes will ask the question, okay, if I can cure X number of people with this cancer, can I actually minimize or change the treatment to get that same outcome, but with less toxicity? So let me tell you a little bit about how that's being done in the field right now. I'm going to talk about a couple practical examples with early stage breast cancer, DCIS or stage 0 breast cancer, and an example in colorectal cancer, kind of bringing in some of what we've understood on that genomics advancement and with advancements in immunotherapy. So DCIS or stage 0 breast cancer, this is really, if you think about the ducts of the breast tissue, DCIS is the abnormal development of precancer cells in the duct of the breast tissue. So these cells haven't learned the ability to go outside of the duct, and that's why they're called DCIS, or sort of that in situ disease. Some of them can be at risk for developing into invasive ductal carcinoma, where then they can spread to other areas of the body. But not all of them will do that. And there's a lot of questions in the as we've learned more about the biology of DCIS, to really ask the question, well, who progresses to invasive disease? And do we actually need aggressive kinds of treatments with DCIS? Or is observation appropriate? And then treat things if it becomes worse. So a large clinical trial, there are actually 3 studies, but I'm going to feature one of them called the COMET study, that actually tried to ask the question, would close observation actually have the same outcomes as aggressive therapy? So in this trial, they took individuals with grade 1 and 2 DCIS, where historically 10 to 20 of these percent of these patients were having aggressive surgery with bilateral mastectomies. And they enrolled them in the clinical trial. Half of them were randomized to guideline concordant therapy, which may have meant surgery with or without anti-estrogen therapy. And the other half of them were randomized to active surveillance, so not actually doing any kind of surgery. They were offered anti-estrogen therapy and they were followed with screening mammograms. And you can see within the study, about 150 people in each arm of the 600 actually said, I don't really feel comfortable with this arm that I was randomized to, but they went on to follow patients with it. And just this past December, what you'll find in the middle of it, they enrolled about 1,000 individuals. The median age was 63 years old. Half were randomized to that active monitoring with just mammograms. The other underwent surgery with or without radiation. And they looked at the 2-year cumulative risk of developing a new invasive cancer. And what they found actually and presented is that in the active monitoring group, they actually had less disease picked up, 4.2% of people. In those who went on to receive surgery with or without radiation, it was 5.9%. And this was felt actually to be not inferior, which really mentioned at this time that, gosh, for low risk DCIS or grade 1 or 2 disease, that maybe we don't need to put people through intensive surgery and radiation in anti-estrogen therapy. There was a subsequent trial that went along with this to really understand the impact on people's quality of life. Was there more fear about recurrence, for example, if people were being monitored? Were there more side effects from anti-estrogen therapy in one arm versus the other? And the quality of life was actually similar in both arms. So how are we actually incorporating genomics into our treatment decisions? And I wanted to use an example in breast cancer where we look at a lot of different risk is assessed using a lot of different features. For example, tumor size, lymph node status, the age of the patient, the grade of the cancer, as well as some of these historical features that I mentioned, like estrogen, progesterone, and HER2. There's also been some computer-generated models called the CLIN score that helps to predict, gosh, what is my risk of metastatic or recurrent cancer? But I would tell you today we really use genomic tools. There are a variety of these. Oncotype looks at 21 features and actually comes up with a recurrent score to look at the benefit of chemotherapy. MammaPrint is a 70 gene assay that has a similar prediction. And so as researchers, we went on to design studies that looked in 3 large studies. One was node negative patients, and they used Oncotype to help risk stratify patients. One was a large MINDAC trial that used that testing called MammaPrint. And the third is a study called RxPonder, which looked at node positive disease, where historically oncology would have said, gosh, you have lymph node positive disease, you all need chemotherapy. And what all of these different trials looked at is they actually randomized patients. In this case, all of them in the RxPonder were considered high risk if they had lymph node positive disease. And they were all randomized to either chemotherapy with endocrine therapy or no chemotherapy with endocrine therapy. The other trials did a similar thing of endocrine therapy versus no chemotherapy. And the MINDAC used a similar platform. They considered people clinical high risk, meaning if you were considered clinical high risk if you had a large tumor or lymph node involvement, but the genomics or that MammaPrint testing actually was considered low risk. And how did that actually compare if you got chemotherapy or not? And what you'll find actually is in those who historically we might have said, gosh, you're at higher clinical risk. You have a larger tumor, you have lymph node involvement, but actually their genes that were expressed were considered low risk. They actually didn't benefit from chemotherapy at all. There was a 1.5% absolute difference favoring chemotherapy. And so today, rather than giving all of these individual patients chemotherapy, we're able to say, you don't need that. And this has actually resulted in what the figure on the right suggests, that about 70% of individuals no longer would need chemotherapy, where historically we would have actually prescribed them. I would say some other advances in breast cancer are specifically looking at that BRCA mutation, where there's a defect in DNA repair. And there's specific drugs like PARP inhibitors that can affect that DNA repair mechanism. Where now, if a patient is at high risk for recurrence, this particular study called Olympia took those at high risk for recurrence and randomized them to receiving this DNA repair PARP inhibitor compared to placebo, and showed significant improvements in overall survival. These drugs are now approved for pancreas cancer as well as ovarian cancer as well. And then what about other kinds of cancers? What other kinds of techniques are actually being done to change how we think about aggressive treatment? So in colorectal cancer, there's a large study called the PROSPECT study. And if you take lymph node positive or high risk rectal cancer, the standard of care, or what's described on here as the control, is to use pelvic chemoradiation, followed by surgery, and in most cases, additional chemotherapy. What Deb Schrag and her colleagues through the Alliance propose is, gosh, I think that with the advances we have in techniques and with advances in chemotherapy, does everybody actually need chemoradiation? And chemoradiation is a great technique. It's made significant advancements in how we can cure patients. At the same time, there's toxicities from it, including sexual dysfunction, problems with control of bowel or bladder, as well as scarring in the pelvis. And in this trial, patients were given chemotherapy first. As long as they had a significant response, they would go on to surgery. If they did not, they would go on to pelvic chemoradiation. And they looked at whether or not this impacted disease-free survival. And what was found in the trial is actually after about a median follow-up of 58 months, there was no difference in disease-free survival between the two arms. There was no difference in the non-inferior overall survival or local recurrence. And in many of these situations, about 1 in 5 people had a complete response where their cancer disappeared with chemotherapy, and they did not need to go on to have chemoradiation, saving them from the potential toxicities of infertility, sexual dysfunction, as well as scarring in the bowel. This is also an example of just how our understanding of the biology of the cancer has actually really impacted outcomes. So there's a very small subset of individuals with rectal cancer that have something called a mismatch repair deficiency. And these patients actually seem exceptionally responsive to immunotherapy. So what the figure shows you on the left is an actual cancer on endoscopy. And these were in patients who had this specific mismatch repair deficiency. So coming back to our advancements in understanding of the biology of the cancer, with the use of dostarlimab, a particular type of PD-1 blockade, after 3 months, that mass disappeared on endoscopy. And it had continued to disappear at 6 months. And this just shows you also the PET imaging of it. This is another patient who had this large mass in the colorectal area that disappeared after 3 months with the use of this treatment. And really, patients tolerated the therapy well with some mild rash and fatigue and nausea. They had an overall clinical response rate with those with mismatch repair of 100%, where all of the 12 patients in this initial study, nobody needed chemoradiation or had disease progression. And this was a really small study. So this is actually now being done in a larger study that we're participating in. My colleague, Dr. Ajay Prakash, is leading, but really suggests the fact that if we can understand the mutations and the changes in the genome, we can actually use specific therapies that balance How aggressive do we need to be with treatment with a goal of long-term health outcomes? So when I think in general about principles of changes in therapies in the curative intent setting, I would tell you that a lot of our advancements about understanding the biology has been changes in targeted therapy. It's been advancing the understanding of the genomics and how that actually impacts treatment. And really, when we think about those living with cancer, I think about balancing cancer control with toxicities. And that really needs balance with understanding the long-term survivorship health needs for individuals, both that psychosocial and financial and impact on family and partners, but also in terms of overall health and toxicities. So where are we going in cancer care? I think really that the next few years are going to be shaped by refinement and combination of these existing technologies. We've been looking at immunotherapy and targeted therapy, but really as a way to advance overcoming resistance and achieving synergy. There are advances going on in cancer vaccines, really looking at neoantigens or mutated proteins that are unique in a tumor, and how can we train the patient's immune system to recognize these. This kind of treatment was recently approved in melanoma. And really, I would say there's significant advances in AI and machine learning. And I'm laughing to myself when I just even mention the word AI anymore, because I don't know about you, but my children taught me in the last week or two that on social media platforms, they can make AI can make all of us look and act differently. But in the cancer space, I would say we're using artificial intelligence and machine learning actually to better understand and analyze everything from medical imaging, like radiology images, to pathology, but also to be thinking about which patients respond to which drugs and therapies, and specifically looking at that next generation sequencing. And then really thinking about how can we use these advancements to accelerate the identification of new drug targets and compounds. And I think with that, I'll take questions from all of you. I wanted to make sure we had some time to see what you guys were wondering about or wanted to hear about.
Thank you so much, Dr. Blaes, for all that great information and research on current trends in cancer care and cancer therapy. We did have a couple of questions come through in the chat. I don't know if you're able to see them
Yeah,
or
I
if you
can
want
see
me to
them.
read them. Yeah,
So
go ahead. I think
I'll go
it
ahead and,
starts with that first one about the relationship between
yeah.
chronic health conditions. Okay, thank you.
Perfect. So the question asks, what relationship exists between chronic health conditions and cancer treatment? Recognizing that some cancer treatments, like chemotherapy drugs, can cause heart damage. So I'll use the example. So chronic health conditions and cancer treatment, I would say this is actually a space I do a lot of work in. There's actually a lot to say. There are significant, as we've learned about advances in our understanding about what's driving cancer, I would say this in many cases, the same kind of research is going on in other diseases like cardiovascular disease. There are actually a lot of overlapping risk factors between cancer and cardiovascular disease. And I'm going to use the heart one as an example, but this could be related to other health conditions too. So while there are things like drugs that can sometimes impact the heart, and that's actually not all drugs, but certain ones. There's actually a lot of other things that can impact the development of both cancer and heart disease. I could give a whole talk just on that particular topic. Some of these, all of you in this audience know really well. Let's take smoking. We know smoking causes heart disease. Smoking can lead to lung cancer and other kinds of cancers. But there's actually a lot of other things like inflammation, for example, that we tend to see both in the development of cancer, but also cardiovascular disease. A lot of my own work is also now looking at how this impacts some of our aging mechanisms, something called cell senescence, where we can actually look in really large cohorts at both cell senescence, which is part of an aging process, impacts the development of heart disease. It impacts mortality. It impacts actually cancer and the development of all those things, but also outcomes and mortality related to them. So suffice it to say, there's actually a lot of overlapping risk factors. So when it comes to control, or how do you prevent many of these things, I'm going to answer that question in kind of two different ways. One is for as a cancer survivor, I would say know what your treatments are. What kinds of therapies have you had? What kinds of, and that will impact what kind of screening you may need. But also know that general health principles around physical exercise, weight management, not smoking, all of those kinds of eating well, the things that stress, sleep, all those kinds of things that we talk a lot about how to stay well, I think actually impact and reduce chronic health conditions as well. I think the next question asks about, can you comment more on research related to the impact of healthy eating and exercise to minimize the risk of cancer recurrence? Well, thanks for that, for coming right in after that other description. So if you look at, I would say there is, because of that overlapping risk factors with both cancer and cardiovascular disease, there's actually more and more data on the fact that controlling those things actually reduces the risk of cancer recurrence. It gets a little messy in the data, but I'm going to tell you sort of two pieces about it. In breast cancer, there's really good data that staying active about 150 minutes a week of moderate intensity, so getting your heart rate up, actually there's about a third less recurrence in individuals who are physically active. We see that same thing actually in colorectal cancer. In some other cancers, there's less data. There's a lot of data in childhood cancer survivors as well. There's less data in some other cancers, but usually what I tell patients is you still want to keep moving, because maybe it might not affect your cancer recurrence risk, but we know that those things help prevent heart disease. And most cancer survivors, as I mentioned to you, are at risk for long-term complications like that. There's less robust, but also a growing amount of literature around healthy eating. Typically, we talk a lot about like a Mediterranean type of diet. I know some of you were on last week's call that I think mentioned some of these things. But thinking about, I would tell you, if you don't know what a Mediterranean diet is, think of just lots of fruits and vegetables, leaner meats, and really, this probably sounds kind of funny to all of you, but do you actually know the ingredients in the food that you're eating? So that's gonna, if you can read the a side of a box, or you're mixing chicken and vegetables, or making a salad with rice and vegetables with it, you know what's in it. That's very different than a prepackaged thing that you don't recognize half of what's on it. And so I would say try to stick with the ingredients that you can recognize. And I think those help impact both recurrence of cancer, but also overall health. One of the other questions was about Gleevec and whether or not this reduces the probability of GIST recurrence. So this is kind of a specific question. So GIST is a type of GI stromal tumor. And Gleevec actually is one of those tyrosine kinases that specifically targets certain mutations. So it actually works against BCR-ABL, which is part of that treatment in chronic myeloid leukemia, but it also targets something called c-KIT. And I would tell you it works very well at reducing the recurrence of GIST. Does every single patient with GIST need Gleevec? I would tell you talk with your doctor about it. In general, if a patient had a GIST resected or taken out, there is a lot of things that are looked at, meaning the biology of the cancer. So some of them are rapidly dividing and some of them are kind of very slowly growing. Gleevec is that pill that can be taken then to help reduce the risk of recurrence. And in some of those situations, it's been shown to be helpful. In other situations, it actually suppresses. So, like if you couldn't resect the cancer, Gleevec works really well. I think the other question comes, can I explain a little bit more about, I'm assuming the question is around PARP inhibitors a bit more. PARP inhibitors, so patients who have particular DNA repair defects, and these are genetic germline mutations, where somebody might be born, for example, with a change in the BRCA mutation, which puts them at high risk for developing things like breast cancer or ovarian cancer or pancreas cancer. PARP inhibitors actually, they help the immune system uncover that DNA repair process and allow your body to then take over and fight the cancer. They've been approved at this point in patients with advanced disease who have a BRCA mutation for pancreas cancer, ovarian cancer, and breast cancer. They are approved in select situations where cancer's been removed and somebody's at high risk for recurrence with certain breast cancers and ovarian cancer, for example. And then very rarely people can acquire or develop one of these changes. And that's something that we look at with next generation sequencing, where these drugs may be helpful for them. So I appreciate all of the questions. I was thinking to myself as I was coming in here about what would my takeaways be for all of you if I had to think about it. And there were a couple things I was thinking about just as I think about the advancements in the field, but also as I was giving this presentation, I would tell you, if you or a loved one have advanced cancer, ask about next generation sequencing. In some cancers, it's very routine that it's done. It's not done in all of them, but I would say the vast majority of them, it's done. So you could ask about that. There's a lot of different ways next generation sequencing is actually done. It can be done internally in our lab. It can also be sent to different labs like Guardant or Caris. In terms of how to stay well, these were a couple of the questions that came up. Understanding sort of what kinds of treatment did you have? I always tell patients, we can't change the treatment that you had. We can recognize how to keep you well by incorporating certain screening. And so know what that treatment is. I would say ask questions about supportive care. So we talked a little bit about physical activity and nutrition. These are hard things to do when you've gone through treatment and your appetite is different, your muscle mass has changed, you might have needed surgery, and you might have been put into menopause with treatment, and all these other things have gone, and you're looking at me like, really? Now you want me to walk and exercise? But I would tell you, there's a lot of resources that the health system has for you, as well as places in the community. So all of everyone as part of our system, cancer rehabilitation is amazing. They focus on cancer fatigue, physical activity. Sometimes patients have chronic pain after their treatment, and I would say ask for a referral if you're not sure where to begin. If you're somebody who's like very active and you're like, wow, but I'm just not where I was before my diagnosis. There's other, some of the gyms in town, like YMCA has a program, a Live Strong program, really focused on exercise in cancer survivors. There's a nonprofit called Survival to Strength that we do a lot of work with that offers, I think, 8 free sessions. So I would say message us or ask about them. And then for those of you that, or anybody you know that are living kind of on treatment or making treatment decisions, I think it's appropriate to ask, which treatment may be the best, but also what's going to have the least acute and long-term toxicity. Because there are times when treatment A and B might have equivalent outcomes. And so if you're somebody, for example, that has diabetes and controlling blood sugars is complicated, understanding which one of them may impact your sugars the most might be actually important. So ask those kinds of questions. And I would just say thank you to all of you for spending the evening with me and chatting. And yeah.
And I know there was a question. Thank you, Dr. Blaes, for those 3 summary points. Just really hit on so many of the primary topics that you covered. One registrant prior had submitted a question about chemo brain specifically. And I think your response about talking to your team about it, see what resources are available. You mentioned cancer rehabilitation, but just that reminder that if you do or have symptoms that it's just not feeling back to where you want it to really be proactive and reach out to your team and address options for resources. So thank you for summarizing that. I'm going to just quickly transition to some of our last announcements. Thank you all for putting your comments into the chats and the comments and questions in the chat. Liz is going to put one more bit in there about our last Thrive session, which is going to be next Tuesday. We have Dr. Tara Rick, who is our cancer survivorship provider in the adult long-term follow-up clinic. She's going to go walk us through those very specific survivorship guidelines. So more along this line of what that you can do as an individual to help keep yourself healthy in the post-treatment phase or even during the active treatment phase. So Liz will put that link in the chat to register. We also have that last live session, which will be this Saturday, October 25th at the Hope Lodge in Minneapolis. And that's going to focus on integrative health sampler. So we'll have some sessions available to you where you can try out various integrative health therapies, some walking, some journaling, some art projects. So check out that link that Liz is going to put in there. You will also be receiving an email shortly with the survey that we'll use to help continuously improve our programming, our survivorship programming, and you will be eligible to win that swag bag from Masonic Cancer Center if you complete the survey. So please take a few minutes to do that. And just again, lastly, Dr. Blaes, thank you so very, very much for joining us with both your time and your expertise tonight. It was really a great presentation. Thank you all for coming, and we will see you hopefully very soon. Take care.
Thank you.